Okay, well, good afternoon, everyone. My name's Fiona Lewis, and I'm the Patient Support Liaison for AMAC. And I'm really pleased to welcome you to the webinar this afternoon. Just in case you're not aware, AMAC is a leading funder of research into bone marrow failure diseases in Canada, and we support patients and care partners across the country who are living with aplastic anemia, myelodysplastic syndrome, and PNH. And in the past year, we've hosted a number of regional in-person patient education meetings, and we're going to continue with these into 2025. And we also continue to offer monthly Zoom patient support meetings. So please check out our website for any of these meetings to register and also to access our other resources. Your line will be muted during today's presentation, but you can type any questions you have into the Q&A feature, and we'll address them at the end of the presentation. So you can find that just by hovering your mouse on the bottom of the screen, and you'll see Q&A where you can type your questions in. And if there's time, I'll also unmute the lines to allow you to ask your question verbally. So please note that today's webinar will be recorded and posted on our website next week. So I'm pleased to introduce Dr. Amy Trottier to present today's webinar entitled Understanding Your Lab Results. Dr. Trottier is an assistant professor at the Division of Hematology in Halifax, Nova Scotia. She completed her undergraduate medical degree at Dalhousie University, followed by internal medicine and hematology residencies at the University of Calgary. She then undertook a research fellowship at the University of Chicago, studying hereditary predisposition to blood cancers. Since returning to Halifax in 2020, she opened a translational research program, has established an inherited hematologic malignancy risk clinic, and implemented clinical germline genetic testing for hereditary hematologic malignancies. Although she treats patients with all types of hematologic disorders, her interest focuses on those with MDS, AML, and MPNs. So with that, I will turn it over to Dr. Trottier to begin the webinar. We're having a bit of a problem showing her camera today, so you can't see her, but hopefully you can all see her slides on the screen here. So over to you, Dr. Trottier.
Thank you so much, Fiona, and thanks for everyone who could join today. So as Fiona mentioned, the purpose of today's talk is hopefully to give you all a better understanding of your lab results and further empower you along your journey and better understanding when you're having discussions with your physicians. So we'll make sure that there's plenty of time at the end of today's talk for questions and answers. And please make use, as Fiona mentioned, of the Q&A section, and then we'll take everything at the end. All right, so just to start, these are just some of my financial relationship disclosures, none of which will be relevant to today's talk. All right, so I'm hoping that by the end of today's presentation, each of you who are here listening will gain a better understanding of the different parts of common blood tests that are done for individuals with myelodysplastic syndrome and related conditions. So at the crux of that is what we call the CBC, or the complete blood cell count, as well as to better appreciate when we typically would recommend blood or platelet transfusions, and to understand a bit about our iron studies and iron results and what those mean as well. So just take a step back. I'm sure everyone who's listening here is no stranger to the concept of having blood tests done and blood drawn. And when that blood originally goes into the tube, one of the first things that gets done with it is it gets separated out into different parts. So it gets spun down in what's called a centrifuge, and that breaks it apart into the different components of blood. So blood, although it looks completely red when it is in the tube itself, is actually made up of really three main different parts. And the red part is really just what holds our red blood cells. And then on the top, when you separate these out, is really the bulk of what's the rest in blood. So most of this is just our water. And this also contains things like our proteins, minerals, vitamins, fats, sugars, everything else. In between, as you can see, is a smaller layer in the middle there. Let's see if I can get my little laser pointer to work there. This is where our white blood cells, so our immune system infection-fighting cells lie, as well as cells called our platelets. So it's really these two bottom layers that together are what we're measuring when you have that complete blood cell count done. So when your doctor is looking at a report of your blood counts, this is what it looks like. So your blood goes through a fancy machine, sort of like is indicated here, called a Coulter counter. And this counts a variety of different properties of those parts of the blood. So the main idea is we're trying to measure the primary different types of blood cells that are in there from those fractions that I mentioned. So this is often, and for those of you who may live in places where you can access your own blood results, I think it's even more important as we go forward to, better understand how to interpret that and what you're actually looking at and best know to what to do with it. So we're going to go through these kind of item by item as we go through the talk and break it down. And as I mentioned, if there's questions that come up as I'm going through each of these, please type them in so that we can keep track and then get to them towards the end. So the first that I want to hone in on and talk about are the red blood cells. And this is something that, of course, is very important and we focus a lot on and is probably the topic of conversations of how things are going. So let's take it back a step. So the red blood cell themselves is pictured here. In the inside of a red blood cell, it's primarily made up of a molecule called hemoglobin. Hemoglobin is the actual functional part of the red blood cell that binds our oxygen. And hemoglobin, red blood cells, and iron are all interconnected because within hemoglobin, iron actually binds at these 4 different sites. And the oxygen then connects with the iron. So without iron and without hemoglobin, we can't have our oxygen carried by our red blood cells. The hemoglobin then is what carries and delivers the oxygen to all parts of our body and then gives us our energy. Within each individual red blood cell, there are millions of these molecules of hemoglobin, and each molecule is able to carry up to 4 oxygen atoms. So hemoglobin, as mentioned, is made up of a protein as well as iron that binds on. And without iron, hemoglobin cannot be made. So that's why iron we talk about is so important as well. So what are the parts in our blood tests that we look at and how do we interpret them in the context of your blood results? So all of these values that are shown here within this red box are all numbers and values that represent features of the red blood cells and the hemoglobin itself. So we'll look at these again kind of individually. So the first is what's called the RBC count. So this actually tells you how many red blood cells, and depending on the units of measure here, in this case, in most of the labs in Canada, will measure how many red blood cells per liter of whole blood. So everything that came out of that tube that you have. So in essence, it's the concentration of red blood cells within your blood. If you are what we call anemic, which really refers to low hemoglobin, your red blood cell count itself is typically often low as well. So this we use as a general indicator. But more probably clinically relevant, and what you may be more familiar with hearing and following numbers of, is the hemoglobin itself. So the hemoglobin is, as mentioned, it's the main part of the red blood cells. And it's actually what makes our red blood cells red. It's the protein that's inside these cells that carries the oxygen to our lungs, carries the red blood cells within our lungs. The lungs deliver oxygen to the hemoglobin, and then it gets delivered to the rest of our body. When we're reporting the results and measuring it, it's actually measured as the amount of hemoglobin as a weight in grams per liter of our whole blood as well. The reference range varies depending on an individual's biological sex as well as their age. And so the one that's shown here is just an example. It may not necessarily apply to you. And it also varies depending upon where an individual lives in relation to their elevation above sea level. When your hemoglobin is lower than the reference range, that's according to where you live, your age, and your biologic sex, that's when we consider the person to be anemic and use the word anemia. Some other measures that you may see, and depending upon what blood disorder a person has, you may or may not hear about this one as much. So this is a measure called the hematocrit. What the hematocrit measures is the percentage by volume of red blood cells that is in your blood. So as you can see by the image at the bottom, when we separate out the blood into its various parts, as we recall, the red blood cells are the heaviest, so they go down to the bottom. So the hematocrit here in the middle, this would be about 50%, where about half is red blood cells and the other half of the blood is not red blood cells. And that would be around normal. So you can either have a higher than normal hematocrit, meaning you have a greater concentration of red blood cells in your blood than would be typical, or you could have less. And again, as you can probably imagine, if your hemoglobin is really low and you're anemic, typically your hematocrit is low as well. In other types of blood cancers, such as ones called myeloproliferative neoplasms, this can be too high, and that can be a problem because it can make the blood a bit too thick and increase risk for things like blood clots, heart attack, or stroke. The remainder of all of those measures that I originally showed you about the red blood cells that come about in a person's lab report really refer to more nuanced properties of the red blood cells themselves, and in particular, size and shape measurements. Of these, the most important and most one that we look at and that can be impacted by things like MDS is in particular the size of the red blood cells. And this is primarily represented by what's called the MCV, which stands for the mean or the average, corpuscular, which means the cell, volume. And as you can see here, this is the standard reference range size for red blood cells. So your red blood cell can either be normal. If your MCV is low, it means that it's a smaller size than typical, or contrary, if your MCV is high, then it's bigger than it should be. And depending upon if the red blood cells are bigger or smaller than they should be, it can provide your physician with some clues as to what might be potential problems. So typically, if your MCV, typically if you are very iron deficient, then that means you don't have enough iron to make your hemoglobin. And if your red blood cells can't fill up with enough hemoglobin, then they are typically smaller than normal. Contrary to that, in conditions like myelodysplastic syndrome, or other causes of bone marrow failure, including aplastic anemia, or with certain type of medications, it can actually make your red blood cell bigger than normal. So that's something that can be used as a clue when your physician's looking at your blood count results as well. The next parameters, such as the MCH and MCHC, are measurements of how much hemoglobin is within those red blood cells. And this is, again, the hemoglobin is what gives the coloration of red to a red blood cells. So if it's low, when the pathologist or clinician is looking at the red blood cells under a microscope, they look more pale than they should be. Contrary, if they're really high and the cells are really packed with hemoglobin more than typical, then they would be a darker color than they would normally see. Again, in things like iron deficiency, usually you see those more pale, and they would also be smaller than normal. The last of these parameters is one that's called the RDW, and this stands for the red cell distribution width. So what this is a measure of how much variability in size there is within those red blood cells. Because you can certainly have more than one thing going on at a time, as many of you I'm sure are aware. So some things may potentially make the red blood cells smaller than normal, and other things may make them bigger than normal. So you end up with a mix. And so this RDW gives us an idea of how big of a mix there is within those sizes. Okay, so that's the main features that will show up on your blood results in terms of the red blood cells. But we have more than just our red blood cells in our whole blood. So another blood cell type is called the platelets. So these are cells that float around in our blood. And normally, if there's not a whole lot going on or problems, they are in what's called an inactive state. But if you have something like an injury or a cut, then these platelets become activated, and their job is really in the first line of defense for forming that scab or that clot to help stop excessive bleeding. So the platelets, they help bind with other proteins that form clots by bringing together clumps of the platelets, proteins, and red blood cells to help prevent any further bleeding. There's a large range in terms of what's considered normal for a platelet count. Consistently, all labs will report the low end of normal at 150, but the upper end is quite variable between labs. So usually somewhere between 350 to 400. And individually, a person's platelet count can vary quite a lot, even within the same day. So if a person had their platelet count measured in the morning, by the afternoon of that same day, it could vary by 10 or 20 points within the normal range. And as you can see, even within normal, that's a 200-point difference. So there's quite a variable range. And really, even the low end of normal, a person can have much lower platelets than that and it not cause an issue, aside from the wonder of why is it less than it should be. So the general rule of thumb is that if your platelets are over 50, you wouldn't be expected to have any increased risk of bleeding, and usually wouldn't even bruise a whole lot more than normal. And in fact, your blood can still clot well enough with 50 platelets or higher that you could have a major surgery, like even a heart surgery could be done, and you wouldn't be expected to have any excess risk of bleeding. It's also safe for a person to be on blood thinners if they're supposed to be, so long as their platelets are over that 50 mark. When we start to get much lower than that, as certainly can happen in myelodysplastic syndrome or other causes where the bone marrow isn't working as well, then you can start to run into signs where you're getting easier bruising and maybe starting to get some minor bleeding issues like frequent nosebleeds, bleeding of the gums, blood blisters, things like that. So usually those start to show up when your platelets get around that 30 or under mark. And that's typically, again, when we would consider it not in a normal situation to be safe on blood thinners, or even medications like aspirin or ibuprofen, because those make your platelets not work as well. And if you already have very few platelets, you certainly want the ones that you have to work as good as they can. When platelets get severely low, and when we say severely low, we consider it when it's hit the 10 or under mark, this is when we see an increased risk of spontaneous bleeding. So this could be bleeding that occurs internally without any particular injury. So common sites for this would be things like bleeding from the stomach or other parts of the bowels, so blood in the bowel movements that are noticed. But also there's a risk of this time of having a spontaneous bleed in the brain as the most feared or dreaded complication of that, because that can be very life-threatening. So if a person hits that range, typically that's when your physician or hematologist would standardly recommend a platelet transfusion to try to keep them above that level of 10, to try to minimize the risk of having those devastating bleeding complications as possible. Occasionally there can be reason to have what we call a higher platelet transfusion threshold. For example, if a patient is experiencing quite frequent and prolonged nosebleeds or things like that, when their platelets are more around 20 or so, then your doctor might opt to try to keep your platelets above that range with transfusion instead. So the next of our major 3 blood cell types is the white blood cells. When these get measured in your complete blood cell count, it shows up as what's called the WBC, or the white blood cell count. And this is simply the number of white blood cells that you have per liter of whole blood. The white blood cells are the main part of our body's immune system. They help us fight off infection, but they also have a role in fighting off other diseases, including things like cancers. And there's many different types of white blood cells that all have slightly different jobs. So this is the kind of the secondary part of the complete blood cell count that is called the differential. So this is where the total white blood cells get broken down into the various different types of cells. So these are the main type of cells that you would normally see on a blood cell count differential. So these include lymphocytes, it's called monocytes, basophils, eosinophils, and neutrophils. The two most common type of cells, or the ones that make up the majority of our total white blood cell count, are the lymphocytes and the neutrophils. Here I've bolded the neutrophils. As many of you on this call may be aware or hear about things like your neutrophil count, or you might hear it called the absolute neutrophil count or the ANC. So the neutrophils are really the workhorse of our white blood cells. These are the ones that help fight off the big bad bacterial infections and are kind of the primary line of defense if you ever have any source of bacteria or foreign invader enter your body. So the normal range of neutrophils is anywhere between 2 and about 7.5. I'll talk next in a little bit more detail about what we constitute as low neutrophils and when we call somebody really neutropenic, and at what levels there's more concern about infection risk than others. So again, what is low? You know, when does your clinician worry about low white blood cells? And when are we telling you that if you have a fever, that it's really an emergency situation? So I already mentioned that kind of 2 is considered the low end of normal, but really if your neutrophils are between 1.5 and 2, that can just be a variant of normal. It's not really much of an issue. We don't see increased risk of infections at those ranges. When you're getting between about 1 and 1.5, that's when we would consider that a mildly low neutrophil count, still not at very high risk of severe infections, but maybe if you get a cold or other infection, it might take you a bit longer than typical to recover from that. But generally, we would still consider anything above 1 as a pretty safe neutrophil count. When you're getting below 1, so between 0.5 and 1, we would consider that moderately low, and as a consequence, that risk of severe infections does increase. And then certainly anything below 0.5 is really high risk of potential for severe infections. And these are the situations where we counsel patients that it's important for them to closely monitor for infections. So that includes regular checking of their temperature to see if there's any fever. At any point, of course, if they're feeling unwell, to check additionally. And if individuals who have a neutrophil count below these numbers do have a true fever, so above 38 Celsius, that is more than just lasting a couple of minutes in time, we do consider that an emergency situation and recommend that those patients proceed to their nearest emergency department because their immune system is often not strong enough to fight off infections on their own, and typically will need things like intravenous antibiotics. So those, as I mentioned, are the normal things to see on a differential. What is not normal or what shouldn't be on your white blood cells in your blood are what's called blast cells. Blast cells may be seen in people with myelodysplastic syndrome or in individuals with leukemia. So blast cells are very young, immature forms of white blood cells that typically reside and live inside of our bone marrow in low numbers. A normal bone marrow should have less than 5% blasts, and none of them should spill over or be seen in a person's blood. But people who have MDS can have a higher blast count, and this is shown to correlate with the risk of disease. So in individuals with MDS, if the blasts in the bone marrow and blood, well, there's no blasts in the blood and there's less than 5% in the bone marrow, typically this falls in line with a lower risk MDS. If the blasts in the bone marrow, however, are higher than 5%, but under the 20%, these fall into categories of higher risk MDS. If that count ever reaches greater than 20%, that is considered acute leukemia. And unfortunately, there is a risk for individuals with myelodysplastic syndrome progressing into an acute leukemia. And one of the main measures we use to look out for that is that blast count itself. And that's one of the main features that your doctor's looking at when they're doing the bone marrow biopsy test, is determine how many blasts there are. Okay, so I'm gonna kind of switch gears a little bit, but this of course derives upon the results of your own blood test, is that when is a transfusion required? So as I was mentioning before, really one of the most important parameters that we look at when we talk about a lot with our patients is the hemoglobin. And again, this is because the hemoglobin is the thing, it's the molecule that's carrying the oxygen to your body, giving it to your heart that you need and giving us your energy. So when your hemoglobin goes too low, you don't have enough oxygen that's getting delivered to your important parts of your body. And this can cause symptoms like low energy, just general fatigue, shortness of breath, especially if you're exerting yourself, and it can cause increased stress on the heart. And that's a particular concern for any individuals who have underlying heart disease that can trigger things like angina or heart failure. So when do we transfuse? And it's not exactly a straightforward answer. We always have to take the individual circumstances into account. And different areas will have slightly different practices for what they would consider a quote unquote standard transfusion threshold. We do know from different research studies that have been done in the past that for certain situations, so for example, an otherwise healthy individual who has no known history of blood cancer, if they are suddenly in an accident and have bleeding as a result of that, or they have a bleed in their stomach or somewhere else, then the transfusion threshold is typically set at 70. So if a person's hemoglobin is below 70, that's when transfusion is recommended. But if it's above 70, they just get watched closely. And that has been shown actually that using it that way as opposed to transfusing a patient in that situation when their hemoglobin is higher ends up resulting in better outcomes for that patient. Now, it's a little bit different for patients who have an underlying bone marrow problem, such as myelodysplastic syndrome or aplastic anemia or other blood cancers, because their bone marrow is not able to compensate as well as somebody who has a healthy bone marrow but otherwise just lost some blood. And these are individuals whose hemoglobin is chronically on the low side. So the standard transfusion threshold that's set for those cases is around 80. You may see here that aplastic anemia falls into two different categories depending on the transplant situation. So for people with aplastic anemia who are planning to go forwards and have a bone marrow transplant, we keep the transfusion threshold a little bit more restrictive. And that's because every time you're transfused with a unit of blood, there is a risk of acquiring antibodies. So it's still a donor's blood that's not 100% perfect match to your own, and your body can recognize some of those differences in the blood and make antibodies against it. And if that occurs and a person develops a lot of antibodies, then it can be hard to find them a match for the bone marrow transplant. So that's why we have that different threshold. But for the individuals who are not eligible for a transplant, they would be more on the standard transfusion threshold. Some individuals may require a higher baseline hemoglobin, and that could be because they have symptomatic heart disease or just otherwise very symptomatic with dizziness, fatigue, or weakness when their hemoglobin falls below around 90. And so in those cases, we would set the threshold a little bit higher for them. Now, when we talk about transfusion, we often talk about iron as well. So each bag of blood, as you can imagine, holds a lot of red blood cells, which holds a lot of hemoglobin, and each hemoglobin molecule, as I mentioned, contains iron. So for every bag of blood a person receives, they're actually getting quite a bit of iron as a result as well. How do we measure a person's iron stores? There's not a perfect test, unfortunately. So what we use as the best indicator of how much iron a person has available in their body to make red blood cells is a molecule called ferritin. So ferritin is actually made in our liver, and it is the thing that stores iron in our cells. And that storage of iron makes it available to use to make things like our red blood cells. So it's used as an indirect indicator of how much iron you have. The only true way to measure exactly how much iron a person has that's available to make red blood cells is measuring how much iron is present in their bone marrow. And I don't probably have to convince anyone here that you probably don't want to be doing a bone marrow biopsy every time you want to check somebody's iron levels. So for that reason, we use the ferritin. There's a big range as well of values for ferritin, which you can see on the scale on the bottom. Typically, a level of under 15 is iron deficiency. So that would be an individual that is lacking sufficient iron and might run into problems with anemia because they don't have enough iron to make those red blood cells. Normal ranges usually are around 15 to 200 or 300 or so. And then you can certainly get to a very high end. And ferritin levels, sorry, these I should specify, these values I'm talking about are the actual ferritin numbers themselves. So when is too much iron a problem? As I mentioned, for people with myelodysplastic syndrome, aplastic anemia, they frequently may require blood transfusions. And with each blood transfusion, you get a lot of iron. So you can start to run into troubles with having too much iron. That risk we really start to see when those ferritin levels get really quite high. So we're talking about at or above about 1500. And who would have really high iron levels? So it's not just those who get repeated red cell transfusions, but we can see high iron levels too in other disorders. Things like alcohol overuse disorder, autoimmune diseases, diabetes, other types of cancers, obesity, overactive thyroid, and liver disease are all causes of high ferritin. And this is why it's important to interpret your ferritin result in context. It's also important to realize that when your ferritin is high because of these things like liver disease, diabetes, alcohol use, it's just because this ferritin itself is being made more, but does not actually mean that there's more iron in your bone marrow itself. When your ferritin is really high, again, that 1500 or more mark, and you've been having repeated transfusions, there begins to be concern that that iron can start to deposit in your organs because there's just so much excess of it. It ends up going places and depositing. And iron is what you would think of it. It's a metal. And so when you have a lot of it that comes together, as you imagine, if you're filling up your organs like your heart and your liver with a metal, they start to not work as well. And in particular concern is the heart. So the heart is a big muscle that has to pump our blood. And if that gets filled up with a metal like iron in excess, metal's pretty rigid. So the heart muscle is not going to pump as well. And individuals can run into problems with heart failure. This is not a process that happens quickly. This is a process that happens when your iron levels are high over a period of many years, and they are gradually depositing in the organs. So it's not something that if your ferritin level is really high on one blood test, or even over a matter of weeks or months, is at high risk of occurring. We're talking about sustained levels that are high over many years. So for patients who have things like a lower risk myelodysplastic syndrome, who are expected to live many years and are doing pretty well, aside from the fact that they're still having to get transfusions pretty often. These are the individuals that your physicians might talk to you about the addition of other medications called iron chelators that help to bind up some of that extra iron from your body and try to get rid of it to prevent those complications. Okay, so as promised, I wanted to leave a lot of extra time for discussions and questions. So that's all I had for slides. And I'd really just like to open it up to the back and forth for individuals or questions that people have.
Great, thank you, Dr. Trottier. Just looking at the questions here. Stuart had one about neutrophils, pretty just generally asking how they fit in. So I think you might have answered that, but Stuart, you can raise your hand if you still have a more specific question or type it into the Q&A. And Jasvir has a question about immature granulocytes. Just get to the question. What is the difference main with immature granulocytes on my CBC 0.01? But I asked the emergency doctor and there are no blasts as far as I am told.
Yeah, so that's a very good question. And it can be confusing not only for patients, but for some physicians as well. So immature granulocytes are referring to white blood cells that are somewhere in between the phase of the really immature ones, which we call the blast, and the fully mature forms, which are called the neutrophils. So normally in our bone marrow, we have progression, just as basically you can think of the blast as the very baby white blood cells. And as they grow up, they go through the different phases. They go through infancy, adolescence, young adulthood, and finally mature adulthood, which is the neutrophils. So the immature granulocytes are things like those adolescents and those infants that are in between. And depending upon the situation, those can be entirely normal to see in your blood counts, especially in low amounts, like you're mentioning. So it's common just to see a few in the blood in any individual. That's normal. Or if somebody is, for example, fighting off an infection, if they even just have a cold, your body's doing what it's supposed to do and increase its production of white blood cells to help fight that off. And just as it's increasing them, it's making more new ones. So you're basically incubating and growing more white blood cells to help fight it off. And in those cases, that would rise up. But a low level that's persistently present in the absence of blast cells is typically not a worrisome feature. Please let me know if you had any other specific point or question about that, or if that helps.
Okay, and Jasper has another one about low iron at 5, ferritin at 105, but she's also had COVID, so just wondering if she should be taking small amounts of iron.
Yeah, and the iron business is tricky because as you've seen, there's a number of different values that are stated for iron. There's the serum iron level, the TIBC, percent saturation, and then there's the ferritin itself. So if the ferritin is under 15, then a person absolutely is iron deficient, and it would be reasonable to take supplemental iron. For a ferritin that is above 50, it's highly unlikely that you're actually low in iron, regardless of what the serum iron level itself shows, because that iron level that they're measuring from the blood is not the actual iron that's available to your body to use. And there can be other reasons. So when a person has any kind of inflammation in their body, that iron measure in their blood will be falsely low.
Okay, great. And Linda asks, any comments re elevated neutrophils as it relates to MDS/MPN?
Yeah, so elevated neutrophils, let's start, oh, so this would be, I assume, the overlap condition. Is that right, Linda? Where you're not asking about for those individual circumstances, but for the condition at which a person has MDS, MPN as their disorder. Is that correct?
Yes, she says.
Okay, perfect. Yeah, so these are disorders where a person has a mixed picture where some of their blood cells may be higher than normal, some may be lower than normal. And in the bone marrow itself, where the blood cells are produced, there's similarly a mix where you have uncontrolled overproduction of some blood cells. And then some of the blood cells that are still being produced, though, are not quite normal in look or function. And that's the dysplastic or the MDS part, whereas the proliferative part is the overproduction. So in those what we call overlap disorders, high neutrophils is not uncommon. And in those situations, it really depends on exactly how high the neutrophils are, if they're of a day-to-day type of concern. It's usually not an infection risk, so we don't see that so much. But if the neutrophils get to the extreme levels of elevation, and by that I mean if they're getting up to certainly above 50 or closer to that 100 range, we start to have concern that those really high numbers of neutrophils are another reason for the blood maybe getting too thick, and that can increase risk of things like blurred vision, bleeding, or if they get really high, things like stroke. But anywhere really under that range is just followed and monitored closely. Let me know if that helped, is that it's getting what you were wanting, or if you had any other specific questions about that, Linda.
Okay, we'll give her a minute to respond and we'll go to Stuart's question. He's asking you if you could clarify the relationship between neutrophils and blasts.
Yeah. So neutrophils are the normal, mature, adult form of that white blood cell. Blasts are the really, really immature form of white blood cells. And those only live normally within the bone marrow in small amounts. And with a normal, non-cancerous blast cell, they mature over time. And so you can think of the blasts as the newborn baby neutrophil. And as a normal blast cell ages, it goes through a variety of stages in the bone marrow, with the end stage being the mature neutrophil. So once you have that mature adult neutrophil in your bone marrow, it then graduates and leaves the bone marrow and goes into our blood, where it functions as a healthy white blood cell. In things like MDS or leukemia, where the blast cells can be cancerous, one, you can get more of them than you should because they keep duplicating themselves, but then they also lose their ability to grow up. So they get stuck in that newborn baby phase. So they don't go on to grow up to be nice, mature neutrophils. And then you don't have the nice, mature graduating neutrophils to go out into your blood either. And that's one of the reasons why the neutrophil count can be low in patients with MDS or AML as well.
Okay. And Jasvir has another question, which may be slipping into the diagnosis side of things, but I believe she has MDS and she's wondering why she's getting blood blisters in her mouth.
Okay. So it's difficult for me, of course, to say Jasvir without knowing all the situations, but if you're forming blood blisters in your mouth, then I definitely recommend you try to see somebody about that right away so they can have a look and a check of your blood counts. And that would be one thing, again, to look specifically at things like those platelets. So if there's reason for your platelet count to be very low, then you can form things like blood blisters in your mouth, which would be forms of bits of bleeding that happen under the skin. And the mouth is a fairly common place for those to happen because we inadvertently sometimes bite our cheek, or just our cheeks rubbing against our teeth, things like that could be enough to cause a bit of bleeding if somebody's platelet count is really low, or if they have another reason to have bleeding issues.
Great, thank you. Yeah, Jazz was just saying platelets are 272.
Okay, yeah, so that's not the problem. So it could be something else. Sometimes it's medications. Sometimes it might actually be physical trauma, again, like gum biting, but there might be other culprits that that your doctor might have to look a little bit more details into.
Right, so important to get it checked out.
Yeah.
Okay. And Stuart says you answered his question. Thank you. Okay. I think we're nearing the end of the questions that relate to your topic. So let me just have another quick look here. Actually, I had one that came out of a webinar we had yesterday with a dietitian who was
Sure.
talking about vitamin deficiency. And I'm just wondering, how patients can get that checked. Is that something that can be added to normal blood work?
Yeah, yeah, and especially if somebody has blood work done that shows that they are anemic, one of the first screens that should be done is for potential vitamin deficiencies. And the big ones that affect our red blood cell production, in addition to iron, which should always be checked if somebody's anemic, is the vitamin B12 level. And in somebody who is a heavy alcohol consumer, or they have a very restrictive diet, then another one is folic acid or folate. So if you're low in B12, and B12, I'd say, and iron are the most common vitamin deficiencies that can contribute to a low hemoglobin. And those are pretty easy fixes. So that would be something that should really be checked in any cause for anemia, or even if a person has myelodysplastic syndrome and their hemoglobin is starting to drop and it used to be stable, it's always good to recheck those things to see if, even if it was normal in the past, if maybe now it's getting low.
And I understand many Canadians are deficient of vitamin D. Is that something that's checked through blood work?
Sorry, did you say vitamin D?
D, yeah.
Yeah, all Canadians are going to be low in vitamin D unless they're taking supplemental. And this is just because of our location on the planet in relation to the sun and the number of sunlight hours that we get or don't get. So it's not something that I'd say is routinely tested for, because if somebody's not taking any extra vitamin D and they don't consume a ton of milk and dairy products, because those are fortified in vitamin D, then it's safe to assume that they are low. And in general, it's just recommended that everybody within Canada take supplemental vitamin D, anywhere between 400 and 1,000 international units once daily. It's not one that if you're low, you would see it affecting your blood counts, but it can have other effects. In particular, it can affect your bone strength and your bone health and lead to premature thinning of the bones. And for young women in particular, low levels of vitamin D have often also been associated with a higher risk of multiple sclerosis. So those reasons, it's generally recommended that people living within Canada just take supplemental daily vitamin D. And the typical standard is 1,000 units a day. And in particular, in the winter months where we don't have as much sunlight hours.
Great, thanks for that. One more question here from Jasvir. I don't know if you can see it online, Dr. Trottier. It's
Yeah.
if you go down to the last question.
Okay. CD4 to CD8 index. Okay. So these are, Jasvir, these are kind of markers more so for specific parts of the immune system. And it's not something that MDS is typically associated with. So these aren't even tests that we would usually do in an individual with MDS. They might be tests that are done in somebody who has blood count issues and they're trying to find out what the diagnosis itself is. So if somebody had low blood counts, but their bone marrow biopsy did not show myelodysplastic syndrome, then they might do some of these other things to check for other different types of diseases. Some of that starts to fall outside of my realm and more into the world of specialists called like rheumatologists and others who deal with those kind of investigations a bit more.
Okay, great. Thank you for addressing that one.
Yeah, I do see, Jasbir, you have an earlier question that in your bone marrow biopsy, it showed iron deficiency with non-stainable iron. So if you did have a bone marrow biopsy that was good quality and it showed that you had low iron stores, then you can take that as a true indicator that the iron levels are low and that iron supplementation would be reasonable. All right, and I also see there's a comment about anisopoikilocytosis. So that's a fancy pathologist term. And what that means is that when they looked at those red blood cells under the microscope, they have a variation in how big they are and the shape of them. And no, that's not always MDS. There's a lot of different causes that can make the red blood cells smaller than they should be or bigger than they should be. And when you see that term, it means there's a variety of those different sizes. So likely there's more than one thing that's going on. There might be maybe inflammation, as you mentioned, low iron. So some things that would make the cells smaller and other things that would make it bigger. In MDS in particular, especially if that's the only cause, we usually just see that they're all bigger than they should be, as opposed to a big mix of different sizes.
Okay, well, I see we're nearing the end, so we better wrap up the question session. Thanks everyone for your questions and for Dr. Trottier for presenting that information in a way that we can all understand it really easily. And thank you all for joining the webinar today. I just encourage you to look at our website for news of upcoming meetings we're having and registration information. And we'll soon be publishing our winter newsletter. So if you haven't signed up to receive that yet, you can do so on the website. So thanks again, Dr. Trottier. Really appreciate your time today. And thank you, everyone else.
My pleasure. Thanks everyone for listening. Have a great
Okay.
weekend.
Good evening. Bye.